Hello, everyone, and welcome to another vitamin D study hour. And today I am excited to have Dr. Richard Cheng here with us. And he is going to be discussing the topic of understanding and addressing vitamin D resistance. Hopefully, you can see my screen. Does that look good to you, Dr. Cheng?
Yeah, I can see that. Hi,
Great.
everybody.
Okay, all right. Just a quick introduction to Dr. Cheng. First off, thank you so much for being here today. I'm really excited to cover this topic. Dr. Cheng is a medical doctor and has a PhD. He is a practicing physician in both the United States as well as China. He has his PhD in biochemistry and molecular biology. He is a Hall of Fame inductee of the International Society for Orthomolecular Medicine and a fellow of the American Academy of Anti-Aging and Regenerative Medicine. He is also the founder and director of Cheng Integrative Health Center in Shanghai and co-founder of the China Low Carb Medicine Alliance. He's recognized internationally for his work in integrative medicine and orthomolecular therapy, and he is the editor-in-chief of the Orthomolecular Medicine News Service. Today we are going to be covering the topic, like I said, of vitamin D resistance. And we're going to be focusing on a paper that Dr. Cheng recently wrote, Understanding and Addressing Vitamin D Resistance, a Comprehensive Approach Integrating Genetic, Environmental, and Nutritional Factors. And we're also going to be referring to a recently published paper, Genome-Wide Gene Environment Interaction Study uncovers 162 vitamin D status variants. That's posted to our website, grassrootshealth.net. And I do want to mention real quick, we put these papers out ahead of time as optional homework. And I gotta say, I thank you to those who sent questions and comments in who actually did read the papers and had questions specifically about the papers. So I really appreciate that you guys have been putting your attention on this homework beforehand. So before I hand the presentation over to Dr. Cheng, just a couple reminders. Please submit your questions to the Q&A box, and all questions will be answered after the study review. Those that were submitted prior to the webinar will be addressed first. And yes, this will be recorded and posted to our website and to YouTube at a later date. So, as most of you know, Grassroots Health has been running an online study on vitamin D for since 2008, and you can get a vitamin D test kit so you can measure your vitamin D levels from home. It is a self-sponsored study, and that is how Grassroots Health can fund its operations, and we appreciate those of you who participate. And then finally, our next vitamin D study hours will be on the 7th of January is our next one with Dr. Hollick, addressing the confusing guidelines that we have to deal with these days on vitamin D. And that is followed by Dr. Barbara Boucher, who will be presenting on the 21st on metabolic syndrome, insulin resistance, and type 2 diabetes. So please email me, jen@grassrootshealth.org, if you have questions, if you have testimonials, and thank you to those organizations that support us. And with that, I am going to hand this over to Dr. Cheng while I get his slides set up. Welcome, Dr. Cheng.
Hi, thank you. Thank you, Jen, again for the invitation. And I also appreciate the work that Grassroots and you, under your leadership, has been doing. It's really helpful for promoting true health.
Well, we're doing this with the help of you and many other of our vitamin D scientists. So I certainly appreciate you joining us, and I appreciate all the work that you're doing. All right, so let me just can you see your slides
Yes, I
okay?
can see it. I can see it.
Great. All right, just tell me when to move on.
All right, go on. Let's start. Well, this is my bio, but we can skip this one. Um, Well, one thing I want to mention about recently, I'm also invited to join the board of directors of the Reardon Clinic, and that's quite an honor, which many of you probably know, which is the world's pioneer with over 40 years of experiencing high dose vitamin C, another critical nutrient to our health. And also another thing, interesting thing is I was invited to join the South Carolina State Medical Board of Reviewers and Board of Examiners as a expert reviewer. And I told them when they did it, I said, I'm not one of your regular guys. I said, because I didn't want to get into arguments or try. They said, yes, exactly. You're the type of experts we need. So that shows the direction, or at least part of the direction that American healthcare is going towards, hopefully. Yeah, go on. Yeah. Oh, okay. So, is that first one or the second one? I think there should be another one. Go back one. Yeah. Okay, yeah. Well, first of all, vitamin D, as many of you know about vitamin D, and we used to think vitamin D is about the bone and the I mean bone, but it's a lot more than a just a bone nutrient. So basically, this vitamin D is not actually it's not really a vitamin. It is a hormone, as we know, and it is a systems regulator. It affects every organ, every cell in our body, literally everyone. Okay, so as pointed out, Cheng just mentioned in a recent paper again, is that vitamin D regulates thousands of genes across every spectrum of physiological functions. So and also important for not only for the bone but also physiological network, immune competence, insulin signaling, and metabolic flexibility, inflammation, redox. You name it, you name it, you got it. So it's widespread. Okay, next one. So we know vitamin D deficiency, as as vitamin D is a critical part of our normal physiology. Its deficiency is a major root driver of all diseases, not just chronic, but also acute, as we have seen, as we witnessed during COVID-19. Where part of my cocktail, integrative orthomolecular medicine cocktail, is high dose vitamin D. I oftentimes give 50,000 units every day for like 7 days to 10 days, and then wean off to regular dose. And as part of the cocktail, it saved many patients from severe symptoms and even rescued people from ICU. Okay, next one. Well, like I mentioned, the vitamin D is a systems signal. Okay, we should consider it as one of the master regulators of our physiology. It's involved, including in ASCVD, basically the atherosclerotic cardiovascular diseases like coronary heart disease, which is the top killer worldwide, at least in the developed nations, and which is also one of the most interested areas for myself because simply I don't want to die of ASCVD, and also in cancer and in autoimmune diseases. Next. Well, this is a summary. Okay, we have so many studies on vitamin D, and I reviewed. Thank you for your questions you sent in advance about vitamin D dosing, side effects, optimal range, and these are common questions that we all do, particularly clinicians, including myself. So this is a summary of these studies and also my view, personal perspective in my in IOM framework. Basically, vitamin D seems to have the blue curve here shows the effectiveness. Okay, clearly we know under 20 nanogram per mil, as the regular guideline says, is deficient of vitamin D. And the vitamin D effects rise very sharply between, the low level to maybe across, close to 50, 60, 70, 80 range. Gradually, it slows down. So, and this is the effectiveness. Up to now, the literature seems to suggest that once you approach probably 70, 80 nanogram per mil level, that's where probably you get most of your benefits. And after that, you still have gain, but a little bit less of the results. I mean, maximum effects. And the side effects don't really show up until above 150 for sure, and probably after 200 more significantly. So my interpretation of the data and summarizing on this graph is that seems to be that vitamin D doses between 50 and 150 is the wide windows of effectiveness and the safety. Okay, within this range, it's I feel quite comfortable. Normally, we of course we say we keep it anywhere between 40 and 50 nanogram and 100 nanogram per meal. Okay, no side effects as far as I know has been reported in the literature with a vitamin D doses, within this range. Yeah, if anything, okay, I'd like to know. And here, actually, I want to raise one important question, interesting question. It's a philosophical common sense issue, okay? We know the Endocrine Society's guideline, and that's a lot of conventional doctors mention, is that they want to keep a vitamin D at the 30 nanogram and above, right? That's the guideline. The issue here is that we do know that above 30 nanogram appears to be sort of the bottom line of the normal range. You begin to see effects, okay? However, that's not the maximum benefits of vitamin D is, okay? So a lot of doctors in practice today, particularly conventional medicine doctors, they sort of aim vitamin D. Many of them don't even do that, but they aim to keep vitamin D up at the 30 nanogram. Here is a question. 30 nanogram is like a passing line, okay? Most of us, we all have gone through schools. And let's say in the school system, I mean, when I was growing up, we had a grading system of 60 points out of 100. 60 is passing, 100 is the maximum. Nobody, it's common sense, nobody is satisfied with 60 because everybody is aiming for 100. Okay? So why in the world here in medicine we would aim for passing grade, which is 30 nanogram, which is like 60 equivalent in a scale of 0 to 100? And that's, shouldn't we think about it? So I'm not looking for only the passing grade of vitamin D, 30 nanogram. I'm looking for what's the maximum that I personally can do for myself and for my patients. Okay. So my answer here is that appears to be, now here's another question is that I have one slide showing that is that now we do know with the existing data, vitamin D is quite safe, at least up to 100 nanogram. Okay. Even above 100, basically 100 to 150, it's still quite safe. Of course, a lot of people are very concerned about going to that range. And of course, I would say, I will add, what I've been recommending is that keep it between 50 and 100 nanogram, no question, don't ask. I'm willing to debate against anybody in any court of law, okay, on this. Going above 100, yeah, sure, I would always add a caution. I said, use it under the supervision of a qualified and experienced healthcare provider. Okay, so that's my view. Keep it between 50 and 100. For between 100 and 150, that's a little bit of window of like a supervision is required. That's where I would put certain disease condition patients, particularly autoimmune diseases. We don't know about cancer, heart disease, these other, whether higher doses are more effective. We don't know the answer yet, and particularly aging. Of course, obviously, I'm getting old. I'm interested in anti-aging. Do higher levels of vitamin D, for example, between 100 and 150, have more effects in anti-aging than between 50 and 100? I don't know the answer. I don't know the answer to that. Okay, but that's an interesting area to search. But right now, I don't, we don't really recommend going above 150. And I have one slide showing in autoimmune diseases, for example, multiple sclerosis, there are some there are some clinical trials shooting for higher, like 200, even 300 nanogram. But that's with extra caution. Okay, let's move on next. Okay, so basically it's already summarized here. So between 50 and 100 nanogram, no questions asked. And to achieve this level, that's the question. And everybody is a little bit different. In my view and in my clinical experience and some of the literature reported papers, between 5,000 to 10,000 IU a day of vitamin D3 is I feel very comfortable. I don't even worry about it. I tell everybody go home, do it. Any problem, I'm willing to go to court with you. Don't worry about it. And so, of course, special conditions like obesity, inflammation, the other conditions may need more, and we will talk a little bit more later. So the key here is that the doses and the blood levels do not have a linear. They don't always correlate. Different people, different conditions, different season, like winter in northern hemisphere right now, we may need a little bit more vitamin D. I go a little bit higher for myself. And of course, we need to measure, we need to adjust, we need to check periodically. Next. Okay, we just mentioned about autoimmune disease. And as we all know, about more than 10, maybe 13, 12 years ago, Dr. Coimbra from, I think, what, Brazil, South America, proposed a Coimbra protocol, basically high dose vitamin D appears to be helpful, effective in autoimmune diseases. And so this is what I do. I usually start with 30,000 IU a day, and I measure their vitamin D level in 2 to 3 months because it takes a little bit of time for vitamin D to saturate our fat tissue in our body. Vitamin D is a fat soluble agent. It takes some time to saturate all the fat cells in our body and to reach a steady state level. It may vary between like 2 3 months. Okay, so we usually measure. At the same time, I mentioned here, we also measure, particularly for high dose range, we measure vitamin D level, of course, calcium, parathyroid hormone, kidney functions, and I may even, creatinine, BUN, and sometimes I even add ultrasound, making sure there's no calcium crystalline formation in the kidney. And of course, we advise people to stay away from high calcium foods or calcium supplements and drink a lot of water. And so that is the autoimmune approach. And as I mentioned here, in some cases reporting supervised clinical studies, 200 to 300 nanogram per mil has been used for short term. Okay. All right. Next. Uh, Next slide. Is this next? Yeah. Okay. Well, so one question is why autoimmunity requires high vitamin D doses? That's an interesting question. As Jane put out upfront and also in advance of those papers, one of the papers is about vitamin D resistance. And we know autoimmune diseases. Let me briefly explain a little bit autoimmunity in my understanding of it. Autoimmunity is a typical multi-organ disease. It's probably one of the best reflections of our poor lifestyle. Okay. My interpretation, as many of you are probably well aware of, is that usually these diseases start from the gut. Okay, we know about leaky gut. We know about this biosis. I'm not going to go into detail. Basically, all these unhealthy diets, the dietary toxins, offending agents, unbalanced bacterium, they create a leaky gut. Basically our weakened gut protective layer. So this allows the leaky gut and dysbiosis. Actually, the dysbiosis is part of the leaky gut. We can call it syndrome. Okay. So basically, that condition allows undigested or partially digested food stuff, as well as of toxins, microorganism, bacteria, virus, these things to enter through our gut barrier into our body. That's the bottom line. For a healthy person, these things normally are not permitted inside, I mean, through our gut into our system. Okay, that's what our gut is. Like our skin protects our inside body from the outside invaders. So because of that, the leaky gut, undigested, all these viruses, all the other toxin can enter a system, and these are highly antigenic. They can cause immune reactions, and that causes the complicated, very convoluted immune reactions we classify into so many different types. Okay, the mechanisms. But bottom line is it starts from poor health. And this actually, interestingly, reminds me one of the, after I actually accidentally helped quite a few skin rash patients. I should have put some cases here today. I didn't. But in my career, I have cured several skin rash diseases, notably, psoriasis. My first case was psoriasis. And then that reminded me of a medical school professor who taught us over 40 years ago. I entered medicine 50 years ago. He was saying a good dermatologist needs to be a good internist first. I remember that clearly. I never understood it. Not until recently, within the last 10, 15 years. Then I realized, yes, actually, a lot of the skin diseases actually are a reflection of our internal medical problems, particularly gut. So, all coming back to autoimmune disease. So, basically, in my view, the root cause lies in the gut. Okay? Now, what does that mean? What I said is that autoimmunity itself is an inflammatory disease. No question there, right? And it's a gut dysbiosis, a leaky gut issue. It's a poor vitamin, nutrition issue. It's a toxic, highly, toxin overload issue. So those are all the conditions that will increase your, vitamin D resistance, as I described in that article. Okay, that's probably why autoimmunity patients require higher vitamin D doses because there are so many other factors that are affecting the vitamin D receptors, vitamin D absorption, and the vitamin D physiological functions, in addition to the genetics. Okay, and next one. So the message here is that the vitamin D resistance, the normal doses don't always work. So that's another question. How do we, make a judgment? How do we judge in clinical medicine whether a patient has a sufficient level of vitamin D? Blood level obviously is still the mainstay. We measure the blood level, but also I would recommend combine the clinical scenario. Okay, if the patient shows very safety profile on vitamin D, no issues, as I mentioned, no issue of high calcium problems, and for example, certain special diseases, you may gradually increase vitamin D doses until basically try to adjust for the physiological response to see where is the sweet spot or the better dose responsive range for that particular patient. Okay, so normal dose doesn't always mean good personal level for that particular person. Next. Well, this is a summary of what the recent the genetic study Cheng mentioned up front. Is they studied, they found about 160, 162 genetic variants that regulated vitamin D across the entire pathway. Basically, these variants affect various levels of skin synthesis, liver kidney activation of vitamin D, and transport of bioavailability. Bioavailability, they're basically whether our body can use, and every individual cell can use the vitamin D or not, and also the vitamin D receptor signaling. So explains again from the genetic level why everybody responds a little bit differently. And every person at different age, different state, probably even different season may respond differently. Next. And also here I want to show one of our recent papers, we don't have time to go into detail, but I just want to mention here. The ICV axis. The I stands for insulin, C for cortisol, and vitamin V for vitamin C. Basically, this idea originally came from Dr. Tom Levy, and he published one article on our orthomolecular net, basically our Orthomolecular Medicine news service. If you have not subscribe to that. It's free. I advise everybody should because we publish really interesting articles there. And so he published one article about cortisol and vitamin C. And during a recent conference in Cancer Care Reimagining in Reardon Clinic, we, Tom Levy and I and Dr. Ron Honeyhackey, the CMO of the Reardon Clinic, we went into further discussion, and I felt I propose actually this is probably more important. Basically, the ICV access also ties into our PHRT. Many of you probably are familiar with bioidentical hormone replacement, basically hormone balance. We know in by PHRT hormone balance, thyroid is the starting point. That's very critical. And now we believe that actually thyroid probably is not really the first. We should start from ICV. The insulin ties into today's widespread obesity, overweight, insulin resistance issue. That's a bottom pathology, particularly for a lot of people, American in particular. I think probably about 80% of people here in this country will have this issue. Maybe more than that, actually. Anyway, so here I show you, I'm not going to quote it, the article we publish here as you, in reference number one, published in the preprints. I'm trying to have it published in an academic journal now because I believe this IVCV access would have a huge impact in functional medicine because you can't balance hormones without a balanced thyroid, without a balanced ICV access. Okay, that's quite critical here. But here I want to show you is that actually ICV dysfunction affects functional D-resistance as we're discussing these two papers. Okay, that's interesting. That ties neatly into this hormone balance system again. Okay, next, please. Okay, so this is a summary and with some cases showing you how different dose having different blood levels. The first two are from Jane's, the grassroots study. Basically, they reported a couple, a husband and I'm sure you are all familiar with this. Is a husband and wife both take 2,000 IU a day. The wife was within like a 40 to 60 nanogram, and but the husband was only less than 20 with the same 2,000. And so the husband needed to take 10 times more doses to reach 30 to 40 level. Basically, the husband takes 10 times more than the wife. That's a very good example, actually. And that shows you many other conditions affect the blood level of vitamin D. And the last two are my personal case. I just highlighted two of them here. One of them is my recent case. Is a 67-year man, basically like one regular Jew on the street. 67-year-old was early level of atherosclerosis, and he wants better care, so came to my condition health care. Basically, primarily for ASCVD prevention. He has some carotid, artery issues. So I gave him in my integrative orthomolecular medicine, I call it the IOM protocol, which I will talk a little bit later. And but he inadvertently took 30,000 IU vitamin D a day for a month. I didn't know that. I asked him to take 10,000. Well, I said, don't worry. I said, let's go check. He asked whether he should be. I said, don't. I said, check blood level and do the clinical work, which we did. Well, sure enough, his vitamin D was 118 nanogram, a little bit above 100, okay, but not too bad. And also, he didn't have any hypocalcemia, no renal function issues, no PTH issues. Everything was fine. Okay, that's 30,000 units a day for 30 days, for a month, he says. Now we have another patient, and this patient, that's not my patient until later. Basically, the mother was concerned about the son. The son was, I think, 20-some year old, and she was giving him 50,000 units every day for, I think, like 2-3 months. And then they did some blood work, found that the blood vitamin D was more than 200 nanogram per ml. Also, he showed hypocalcemia and acute phase renal function, basic acute kidney injury. Okay, so everybody is a little bit different, of course, So that shows you the doses, here. But in general, I recommend 5,000 to 10,000 units to practically every adult, and no questions asked. I don't worry about any overdose there. Okay, next. Okay, so up till now, that's my summary of my take in vitamin D in a common sense style. And let me just summarize there is yes, vitamin D, a lot of mechanisms, a lot of other issues involved, as I summarized, basically, regardless of the health conditions, disease, whatever, I put them into 50 to 100 nanogram per meal. That's my target. And as a clinician, I care more about clinical, outcome rather than, the mechanisms, the why, the reasoning is all helping us to form the conclusion and to safely manage patients. So 50 to 100 nanogram. For autoimmune disease patients, I would push for 100 to 150. Of course, monitor, okay? For individual patients, I may even push higher. And so that's the bottom line of my take on vitamin D, okay? Now, should we take a break or should I go on for the second part? Okay, I will go on. So now I will talk a little bit. Let's go back to the 2-1, the first slide, the other slide. Yeah, basically, in my 50 years clinical history, I mean clinical medical career. So Mike again is I'm a clinician. I want to myself to be healthy and anti-aging, and I want patients better. Okay. So here, first few slides, I want to summarize my view on conventional medicine. This is a good. We know blind people feeling the elephant, right? Everybody feels part of it. Okay, next. But we're not seeing the whole patient. This is another view. Basically here, today's medicine, as we all know, is that actually there's something called translational medicine. Translational medicine today, I think it's misinterpreted, is that they directly translate lab research into clinical medicine, basically one drug. Okay? We do need basic research, as shown here, represented by this pretty lady here looking through a microscope. For basic scientists, we need that. I did that too for my PhD. We need to break down the complex systems into parts and study mechanisms. We need to know why. But important as a clinician, we need a holistic view. We are not treating mechanisms. We are treating the patient. That's the problem. That's the whole point here, okay? Because conventional medicine today, they confuse the two. Whether intentionally or unintentionally, okay? A lot of it, I believe, is intentional, okay? So today's problem is that if we, but anyway, summarize here. If we treat a patient through a microscopic view, we mess up, okay? Okay, next. So this is summary. I'm not going to go over the detail, but it's a summary between the conventional medicine and what I call integrated orthomolecular medicine, or actually the true medicine should be, okay? So roughly is that here, summarily is that we need to treat root causes. What is the ultimate root? Let me tell you this, even among the functional medicine, alternative care medicine scientists and doctors, I feel a lot of them missing this point. We are so used to dive deep into the mechanisms. Okay. I used to do the same. When I was a younger doctor, I had my hands behind my back, the nose, eye to the ceiling, very arrogant, very proud. I'm a proud doctor talking about mechanism, something. I'm very intelligent and smart. Thinking back, that's very stupid. That's very stupid, actually. But unfortunately, many of us, doctors, scientists, we cannot escape that, brainwash the mechanism of thinking. Okay, we need to break out of the box. So first of all, for every disease, everything, we need to really trace back to the true root level drivers, whether directly or indirectly. Okay, but I'm not gonna go over this just for your reference here. Now next, because of the time, we can discuss a little bit later. Okay, but anyway, this I think here. This slide, I put it up in a recent cancer debate hosted by the Children Health Defense. That's part of like a think tank to the Bobby Kennedy or HH secretary. So I was invited to debate among cancer, whether it's a genetic disease or mitochondrial disease. But this is one of the slides I took from there, is that, in the center image, as you see here, the SMT, okay, somatic mutation theory, the traditional cancer genetic theory. The MMT is mitochondrial metabolic theory. Basically, we believe mitochondrial damage is the core of the cancer, okay, or antibody or many other mechanisms. The point I'm making here is that these are all mechanisms or the why the cancer happens. But these theories don't address what causes cancer. Mitochondrial dysfunction didn't cause cancer. Mitochondrial dysfunction is a pathway, is a mechanism, or genetic mutations. This actually I want to, expand a little bit more. Think about it. Even in conventional medicine, we believe, if you look at literature, the literature says more than 90% of cancers are caused by carcinogens, right? There's no argument there. But why in the clinical medicine and research we focus on mutation? Mutation is a result, is a consequence of carcinogens in the conventional medical theory. So we need to go to the root cause, which is the carcinogen, as part of it, at least, right? That's common sense. But today, have you ever heard any oncologist talking about carcinogen? No. Okay. So this is not just for cancer, but I use this to illustrate. So for me, I care more about what are the root drivers that cause either genetic mutations or the mitochondrial dysfunction or other chromosomal or genetic or any other mechanisms that ultimately lead to cancer or other diseases. That's how I think. This is what we call root cause analysis. Unfortunately, in today's medicine, we don't have root cause analysis, period. Everybody, every listener, we apply this subconsciously in our problem solving at home, at work. Something happens, you want to figure out why, right? What really caused the problem? And unfortunately, that important piece is missing in today's medicine. Okay, next. So the message of the previous one is that, yes, we need to understand mechanisms. Mechanisms, you can always argue. I tell you, as far as there are humans, there are people who will never end up finished arguing. There will be always endless, okay? However, root cause levels are only those 10, which I forgot to tell you. I already published. I uploaded on preprints, okay? In my view, practically every root level causes will fall into one of those 10 categories. Okay, this is another hallmark. Okay, so we know the last 20 years or so, hallmarks medicine becomes very popular. The very first one or two are cancer and aging. Okay, for example, here's the hallmarks of aging. I didn't show here due to constraint of time. The hallmarks of cancer. But again, if you look at these, I'm sure you all know about it. These hallmarks, whether it's aging or cancer, they are only talking about what happens in these cancers or aging, not what causes. For example, telomere attrition, genetic mutation, like I mentioned, mitochondrial dysfunction. These are the manifestations, okay, mechanisms, not the root causes. We need to go further, okay? So what I call it the hallmarks medicine, that treating patterns, not causes, okay? We need root cause medicine. Okay, so basically hallmarks medicine see the trees and we want to see the forest. Okay, next one. Oh, I listed here. This is the 10 root drivers I listed here. And the lower level, it's on preprints. And here today we're talking about vitamin D. As I listed here, micronutrient deficiencies. Vitamin D is one of them. And you all know, I would say at least 80-90% of the population worldwide are vitamin D insufficient or deficient. In a way, if you don't get enough sunshine, you are deficient, period. You are insufficient, period. Okay, there's no question about it. This is again, vitamin D is a great example I always use, is because we all know, everybody knows vitamin D is a sunshine vitamin, okay? And we humans today don't get enough sunshine as we used to after high rises and Western suits, fancy clothing, we stay inside more than others. So if you don't get sunshine, you don't get vitamin D. Period. There's no questions about it. Next. Okay, so here is another philosophical, conceptual issues. Okay, we are all used to treat the diseases with so-called guidelines or FDA, standards. Okay, well, whereas those are, do serve their purpose. However, there are, a lot of issues. Okay, here is my view. Let's go back to Hippocratic Oath, do no harm to patients. Okay, so my view today is that when I apply an, experimental, including higher dose vitamin D, the first principle I follow is safety. Whether what I'm going to do is safe enough. How do I judge whether it's safe or not? Not only the logic, physiology, but also literature search. We need common sense. We need physiology, biochemistry knowledge, okay? But also some preliminary study or expert experience. For example, me, I think I am one of the experts, and my clinical experience is part of the evidence-based medicine. So first of all, safety, okay? Guidelines second, okay? So, and with this, why is this? Because we know America is a litigious country. I prepare always myself, whatever I do, always prepare. Can I defend myself in a court of law? When I have this in the back burner, I never, knock on the wood, saying thank God, so far so good. Okay. So first of all, safety first, then effectiveness. Okay. In terms of effectiveness, I also first think about physiology and biochemistry. Does it serve a physiological, biological role? If it does, it has a place. Okay. Then look for clinical evidence, and mechanisms do matter here. Okay. Thirdly, affordability and availability. And not everybody has access to everything. So when I have those three, I recommend to my patients. It's that simple. So I don't use any other guideline. This is my guideline. I also had it published. I mean, not peer reviewed yet. It's in the official preprint. Okay, next. So this is my guideline. And so this is my sort of blueprint or the sort of thinking process or the protocol, what I call it, the IOM blueprint for health and longevity. Lifestyle first. I always go in this order: free or inexpensive first. Okay, don't put cart in front of the horse. Don't start with fancy, expensive stuff. I see that too common in the marketplace. Okay, you lose reputation. You are not serving a patient purpose. All right, it's not. So basically, don't advise stem cells, IVNAD. These are all fancy marketing gimmicks in my view. So start from cheap, free lifestyle. Yes, this is time consuming, energy consuming, but you gain, this is their conscience. You make you feel good, and also you gain reputation, you gain more clients. As right now for me, I'm just so busy. I got too many patients. Well, not too many. That was always good. But what I'm saying that the message is, you got my message. Lifestyle first. Nutritional deficiency, as I mentioned, vitamin C, vitamin D, magnesium, and other, critical vitamin minerals, very widely insufficient worldwide and deficient. Okay. Detox. Toxins actually, now more and more evidence, toxin overload, more and more studies begin to show this may be more critical than anything else. Okay. For example, the last 30 years, the early onset cancer, basically patients younger than 50 years of age having cancer, the frequency has increased by 80%. Why? Is that because of genetic, hereditary genetic mutation? No. It's because primarily of the overload of toxins. Okay. So toxin and detox is very critical part. So the first three, I believe, is the foundation. These actually don't have to cost a lot of money. Okay, I always tell people, you go on the right side is my recommendation of my dietary guideline. Basically, you follow this low fat, low carb diet, low ultra processed food, and you supplement at least the basic vitamins C, D, magnesium, K2, and omega-3, and detox, exercise, drink a lot of water, stay away from these, over processed food, these things. If you do these three, within a month, 1 to 3 months, your health will improve. And these things don't cost you much. As a matter of fact, if you quit these coke, these ultra processed foods, actually may save you money. Now, move on further. Mitochondria is the center, is the core, okay? And you focus on mitochondria, nutrition, hormonal balance. I mentioned about ICV and thyroid, cortisol, and sex hormones, and of course, biologicals and the regenerative medicine, stem cells, exosomes, peptides, all these things. But only after you fix the foundation. So in a recent, I already uploaded onto preprints. I intend to publish these as academic journals, articles. Is that anti-aging medicine has two parts. The first is to restore. Okay, upon restoration, then you do regeneration. Okay, don't put cart in front of the horse. Next. So, so with that, these are the first few slides I mentioned is basically my conceptual thinking summary of how I view health and medicine, and the purpose is for health. Okay, first, this is personal. I want to help my parents, myself. These are my father and my mother, 90 and 88 right now. I'm very healthy. Their health is much better than 10 to 15 years ago. Okay, and the here is an ultrasound picture here, and we had a family comprehensive physical exam in Shanghai earlier this year, about 10 months, 9 months ago, and. Not surprisingly, or surprising to the ultrasound doctor, our the carotid artery is squeaky clean, no problems at all. For 88, 90, and me 66, that's very unusual. Okay, so to me that's not surprising. Okay, that's one. Number two, I should highlight it here. Both my parents used to have very high blood pressure. Their highs can go to like 220, even higher. They are low and the diastolic blood pressure, oftentimes in the 110, 120, very high, scary. I used to give them like a five, I think at one time it was high, five prescription drugs, but the blood pressure hypertension was pretty unstable, fluctuates a lot. That was like 20 some years ago. And later on, I changed. I've been learning functional medicine, also molecular medicine, low carb medicine. Basically, I changed their diet, I changed their nutrition, and whatever I've been teaching today. My parents really believe me. They take all my advices very religiously, and now their blood pressure is very stable. Oh, I'm sorry, there's typo here. 130. It's about 120 some to 130 over 70 to 85. 85 is about high. They usually, I don't see above 90 now. Okay. Pretty stable. Okay. I might add. Okay. So that's a bigger, major improvement. And also, my mother used to have frequent, PVCs, the ectopic beats of the left ventricle. And she can feel the palpitation. Now she doesn't complain anymore, and they feel a lot more energetic than before. And they live independently. They don't. I want to hire maids and have. They don't want any. They live by themselves still. But I travel to visit them quite often. Yeah. Next, for myself, I want to be healthy. This I want. First of all, let me play a. Oh, Jen, can you click on that play button? A short video, like yeah. Oh, no sound over there. It's all right. Okay. All right. Let me explain a little bit. I love badminton. What I showed you here is that I often, when I play badminton, I'm kind of all out. And oftentimes I like to, save every shot possible. Okay. Oftentimes I fall down like this, I jump to save these shots. And my partners, oftentimes they are 20, 30 years younger than me. You on badminton court, how many 60-some-year-olds you see? You don't, okay? And so oftentimes they will say, oh, Richard or Dr. Cheng, are you okay? You have bone. I jokingly tell them, I say, don't worry, my bones may be stronger than you. And here on the right is my bone marrow density a few years ago. As you can see the dot, the cross right on top there, and that's my bone density. If you draw back to the parallel to the on the y, this is the y-axis, my bone density is probably better than 80, 90% of people in their 20s and 30s. Okay. I don't take calcium. Again, here, I want to mention, do not take calcium supplements. Okay. I know some vitamin D experts that this is a little bit controversial, but my interpretation, do not take calcium supplements. If you want to know why, read Tom Levy's Death by Calcium. Very convincing, excellent book. Okay. So I don't take any calcium supplements. And I've been taking all the IOM, high dose vitamin C, sufficient vitamin D, magnesium, omega 3, and all the other things. Okay. And that's why I can jump on, I can fall on the floor, no problem. Okay. All right. Next. Oh, I was gonna one thing I want to say about this endurance. One key thing in my view is that I my exercise endurance is much better than most other people. 20, 30 years younger. Okay. And why is that? Because of this. Because of time, let me go a little bit faster. Here, I'm going to review a few cases here. This is one of the complete reversal, yes, complete reversal of coronary artery heart disease. This patient had up to 69% LAD, left coronary artery narrowing or stenosis. In 20, this is, I think is a 20 months. Yeah, 20 months completely gone. Okay, just documented by the CTA, the angiography. Next. This is another case, a complete reversal of coronary artery disease again. She had, I think, 70% coronary stenosis. This is 2 years, exactly actually, in 4 years right here, and 0% now. Okay. Here I might to add, I want to add actually the previous lady. Not only her coronary artery disease stenosis reversed, but also her lung nodules, thyroid nodules, one disappeared, one improved. Interestingly, her aging spot on the cheek faded significantly. What does that mean? Because we are targeting the root causes. Chronic diseases can be reversal. Okay, next.
Okay, we have like 1 minute so that we can
Okay.
address questions.
Okay. Well, this is summarized here, but go on. Yeah, they can review my slides. You can share with them. Yeah.
Okay.
Go on next. Yeah. Well, this is varicose vein also, improved. Go on. Next. A cancer, actually, with the same approach, this patient is now 7 years, 8 years now, cancer free. Next. Okay. So basically, I didn't show you because of time. We also, with this same approach, IOM, we improved autoimmune diseases. Yes, Hashimoto's, lupus, osteoporosis. Yes, irreversible. We have several cases of osteoporosis being cured by bone marrow. I mean, measured by bone marrow density. Okay. And next. Well, this is actually to join me at this 21st century medicine because I'm summarizing these things in a book, and we can read here. All right. Any questions? Yeah.
Oh, yes, we've got a lot of questions.
Okay, please go.
So I'm going to stop sharing the screen right now. I saw a few questions came in while you were doing your review, but I'm going to just go ahead and read through some of the questions that were submitted ahead of time. And I know you addressed some of them already. But first, I'm going to say this is from Dr. Nazir Eddin Kabir, a PhD in nutrition in Algeria. And he says, in recent years, we observe a growing number of individuals with adequate or even high serum 25 hydroxy vitamin D levels who nevertheless exhibit functional signs of vitamin D insufficiency. From your clinical and mechanistic perspective, how do you interpret the concept of vitamin D resistance, and what role do factors such as magnesium deficiency, chronic inflammation, obesity, genetic polymorphisms of the vitamin D receptor, and impaired hydroxylation play in this phenomenon? And I know you addressed some of that, but if you have additional comments, that would be great.
Practically, we already covered all those, and like I mentioned, multiple factors. For example, specifically, vitamin D, magnesium, vitamin K2 are sort of tied together. And we know one we mentioned about a little bit earlier, magnesium and calcium are antagonists to each other. So we should never discuss calcium without discussing magnesium. And we know vitamin K2 is also sort of, soft tissue calcium that deposit antagonist, so to speak. So, so that's a very important part that I use in my protocol. For example, personally, I take 45 milligram, yes, 45 milligram of vitamin K2 daily. Why? Because that's the minimum in at least one study, minimum concentration or level showing that it is, by itself is able to reverse osteoporosis.
Mhm.
And it's expensive, but I can afford it, so so I won't take it.
There,
Yes.
yeah, there was a question that actually came in while you were talking on the same topic about vitamin A, which
Uh,
is necessary to modulate vitamin D function. And he says it's a common partner. The active form of vitamin D or calcitriol must form a complex with the retinoid X receptor, a vitamin A receptor, to activate target genes. If high levels of vitamin A are present, its metabolites can dominate or utilize much of the available RXR proteins, leaving fewer available to partner with the vitamin D receptor. This competition for the common RXR partner can compromise vitamin D's ability to carry out its functions, such as regulating calcium metabolism. And he argues it is hormones from the serum to the cytoplasm that are upstream. Cortisol and insulin are downstream. Do you have any comments about that?
Yes, actually, that's the next excellent question. The question is, again, like I mentioned, in today's medicine, we sort of, look at the holistic, look at an individual, only look at one part. When we talk about vitamin D, we only talk about vitamin D and not vitamin A. Well, let me tell you, I already mentioned a little bit about vitamin C and, ICV excess. I mentioned a little bit, but you can talk a lot. Practically, we have to remember our body is very intricate. God or Mother Nature designed our body to be very complex. It's beyond our comprehension. So, how do we deal with such a complex system? My view is that first of all, we admit there are so many other factors working together as a teamwork. Okay, that's number one. Number two, so individually, I try to study all these vitamin A, C, magnesium, D, to see what is their safe level and optimal range. Okay, and then I try to manage these levels to. Right now, I'm trying to aim for the midpoint of the normal range within these. For example, vitamin A included. Yes, the commentator was absolutely right. The few hold weight, I mean, like I mentioned, there are so many other factors. So basically, what I'm feeling right now is that regardless how these mechanisms work, how these toxins work, my view is that if it's toxic, if it's a foreign thing to our body, try to use as little as possible. Okay, ultra processed foods are not natural. Try to minimize. I'm not saying it's impossible to completely get rid of from our life, but minimize intentionally at least.
Mhm.
Okay, so basically, what our body doesn't need normally is not part of our body. Try to be very cautious when using it. I try to stay away from those things. Our body normally is part, whether it's a mineral or vitamin, it's normal part of physiology, biochemistry. Try to see what is the best, optimal level and achieve that. In my view, regardless the chaotic mechanism in between, everybody can talk 10 days or, on these things, but nobody will agree on any. Why? Because my view is that I don't care how it is. Let's do this. And you know what? Clinically, as I personally experience, many health conditions, diseases improve.
Right.
That's the answer. Yeah.
Thank you. And I do see a couple questions about specific slides and a couple comments. And I just want to say I'll send these to you separately, Dr. Cheng, so that I can
Yeah.
communicate the answers with the individuals asking. And you
Yeah.
can always follow up those who are watching with me, Jen, at grassrootshealth.org, if you still have questions that we don't get to. I wanted to mention another question. So, for years, I've read Grassroots Health from the beginning, I believe. So, I've long been encouraging people and patients, I'm a nurse, to work hard to get their vitamin D levels to at least 50, and if possible, even higher. But now
Great.
I'm getting some pushback about vitamin D supplementation might interfere with melatonin production and thus impair sleep. How do I answer this? I would like to hear more about the interaction between melatonin and vitamin D. I read your paper and it does address it nicely, but it would be interesting to discuss it and expand upon it.
Yes, that's a very interesting question to me. We again should think to be back, put these things into back of physiology. Vitamin D, we know it is actually a sun-rising hormone, right? It's a daylight hormone. It's a regulator of our circadian rhythm. So when we, naturally, when we during daytime we get out, we get sunshine, vitamin D level goes up, and yes, it can helps regulating the melatonin. It does indirectly probably. And so some people may experience if you take vitamin D at night, it may have a little bit awakening effect, possibly. But actually, more predominantly for those people who are deficient in vitamin D help their sleep. That's
Hmm.
more common, yeah. We
Hmm.
know these are like sort of biphasic. When you're low, when you vitamin C the same. Vitamin C actually calms your brain, calms your adrenal cortex, but it also because gives you more energy. Some people report they feel a bit energetic. So if that's the case for you, we'll take it in the morning, like the sunrise. Take it in the morning, right? So that's very interesting. I talking about here. Actually, I want to add a little bit more melatonin. Interesting. Melatonin, we have two sort of, we have the pineal gland secreted melatonin, which plays more into our circadian rhythm. But we also have a lot of melatonin in our mitochondria, which is locally produced and locally effective antioxidants. So those are a little bit different. Yes, anyway, in summary, vitamin D does affect vitamin D, but that's not the reason not to. Okay, we mentioned the 50 great, that nurse is doing great job helping our patients, and that's okay to be 50. If you want to push higher to 80, that's fine. 100, that's fine too. Yeah.
Yeah. And so I think you also addressed a question that just came in. What influence does vitamin D have on sleep? And I've also seen the studies
Yeah,
that correcting deficiency can improve sleep.
that's right.
Um, and so I'm going to mark that as done. And then, okay, I have another question. And I would like to hear your view on this because and okay, for someone with accidental overdose of vitamin D for a few weeks, reaching a level of 160 nanograms per milliliter, which I'll pause there because I wanted to know how did they know that they overdosed or they just accidentally took more than they wanted because I wouldn't see 160 as being toxic yet, as you addressed in your presentation. But I'll continue on with the question. Is it advisable to take high doses of magnesium and K2? Because there was a study from Grassroots Health that participants taking both increased their vitamin D levels substantially while taking the same amount of vitamin D. I'm worried that by taking more magnesium and K2, the vitamin D levels will rise higher.
Well, again, yeah, we already mentioned this. I never take or I never advise any particular nutrient supplement alone. This is my holistic view. And talking about magnesium and K2, those are very critical questions. Like I mentioned, ASCVD is the number one killer, the top killer for developed areas, nations. And so personally, this is one of our most interested areas. And as we should know, whether hypertension or SCVD, calcium deposition into blood vessels is a critical issue here. Okay, how do we do that? How do we counter that? Is first of all, don't take calcium supplements, period. We got plenty of calcium in our foods. Okay, those people who think our food is lack of calcium, people don't have enough calcium, most likely because of vitamin D deficiency. They don't absorb enough. Okay, because we know vitamin D insufficiency is at least 80%, maybe more. I think more. But anyway, so that's first. Number two is that we want the magnesium to come. Calcium is a exciting agent in intracellular exciting agent. They increase your cellular excitability. They make your cells spasmodic. Okay, so that's why you have leg cramps, you have headaches, you have tension that contributes to that, and also ectopic beats. Magnesium antagonizes that. So magnesium relaxes cells. Okay, today most people are magnesium insufficient and calcium too much. Okay,
Mhm.
now potassium, I mean K2. K2 is critical is because now we know not only middle age to older people having calcium, basically calcium deposits in our soft tissues, lungs, thyroids, and breasts, prostates, but also blood vessels more critically. Young people, even younger than toddlers, they've been reporting this. Okay, so I say K2 should be if you can afford, take as much as you can, not just 100 microgram, 200 microgram. That's the minimum. Like I said, I myself take 45 milligram. At least for those people middle age, I recommend 1,000 microgram or 1 milligram. I recommend magnesium, at least, the elemental magnesium maybe around 500-ish, magnesium glycinate maybe 2,000-ish milligram a day. I'm good because these things are very safe. Again, safety first. Magnesium is very safe by mouth. The worst case scenario, diarrhea. Okay. Yeah.
Okay, and I do want to comment, our very last vitamin D study hour was on that topic of the calcium to magnesium ratio with Dr. Sunil Wimalawansa. So there's a lot more information on that topic posted to our YouTube right now. And I'm going to end with just a couple of questions kind of combined, and then I'll follow up with a comment. Um, but I do have somebody who asked, who's a nurse. Do you recommend a reputable orthomolecular program for nurses? And then I also had somebody write in, and she asked which specialty doctor would be best to work with to get optimal vitamin D and mineral levels. And she specifically pointed out the imbalance of calcium and magnesium.
That's a very excellent question. And as Jane mentioned, I'm the editor-in-chief of also Molecular Medicine News Service, which developing these training courses is one of my strong interests. But this is a teamwork, and I think Jane, maybe 2, 3 years ago when we had our first global conference, we mentioned that I would need a lot of organizational help because I think I am more of a physician scientist type of person rather than organizer. I'm not, but I like to, yeah. But our also Molecular Medicine News Service, we publish these regularly. And as you may have noticed, I'm about to write an article, editorial on that magazine, telling the readers what I'm thinking, how basically like today, I'm talking about conceptual issues first, then we dive deeper into each detailed things because I get questions from patient readers want to detail the discussions. Yes, I know we need that, but don't forget the big picture. I like to see the big picture first, right? So yes, and in terms of vitamin D and the magnesium or these things, this actually my advice is looking for an experienced also molecular medicine doctor, particularly from Grassroots Health, Cheng's group, and also Cheng is, by the way, she's on our editorial board at also Molecular Medicine News Service. Okay, so we work together, and also at also because these are the kind of people. Our also molecular nutrition is more than conventional nutrition. It goes much into deeper into mechanisms, all the ins and outs than functional medicine or any other fields.
Right. Yes. So, again, email me, my email, Jen, at grassrootshealth.org if you have questions or want specific referrals, because we do work together. We've got a great network and I can always refer out as well. I'm going to end with a comment. Dr. Cheng, I read your article on understanding and addressing vitamin D resistance with great interest and attention. The entire analysis is excellent. I believe that resistance only occurs when there is an inadequate vitamin D level but a lack of action at the receptor. Other times it is a deficiency, which is not the same as resistance. Undoubtedly, patients with cancer or autoimmune diseases should have much higher levels than 40 or 60 or even 80 to 100. Do you have any comments on this? And we'll end with this one.
Yes, I like to see, if we can having organized, because I'm an individual, but if we can group together, do studies, like I mentioned, I think you mentioned, I like to see what is really the optimal range for anti-aging. And like I mentioned, anti-aging should have two parts. The first is the reversal or prevention of chronic diseases. If you don't die of cancer, if you don't die of heart disease, then we can talk about anti-aging. So, so first of all, what would be the optimal range? The second is, can we start designing or thinking at least of studies to push towards that direction? That is a very interesting area.
Yeah, and I would be curious, because Dr. Coimbra himself, he determines the optimal dose based on the PTH level, not the vitamin D level. And so it would be really interesting to add those types of measurements to a study so that we can see the variability in what somebody's optimal dose
Yeah,
needed for overcoming that vitamin D resistance
yeah,
could be based on looking at PTH and other markers.
yeah. Actually,
Um,
may I add something? Yeah,
Definitely.
yeah, I think, out of all these, we're talking about root causes today, and talking about the regulatory mechanisms, I think, are more critical. For example, oxidative stress, inflammation, mitochondrial function. And today we just added the hormonal regulation, the ICV, into the BHRT axis. I think when we determine the ultimate the outcome, we should address these, or at least include as many as possible, in our study, in our thinking, not just one.
Right. 100% agree. And with that, I want to thank you again, Dr. Cheng, for joining us
Anytime.
and covering this very interesting topic. Do you have any last comments, questions, anything you want to close with?
Oh, wait, okay. I think this is a great field, and those who came to our conference obviously realizes the deficits in the conventional medicine, and we should push forward towards patient-oriented healthcare. And so if possible, let's join together and let's promote true health. I'm not against making money, but patient care first, healthcare first, money making second.
Thank you. All right. Well, thank you again, everybody, for joining us today. I'm looking forward to seeing you again after the holidays. Happy holidays.
Happy holidays, everyone.
Hopefully, you join us on January 7th with Dr. Michael Hollick. All right. Have a great day.
Bye bye, everybody.
Thank you again.